Is it 401? This is good. Yeah. So if we have people online through the CNN. So it's a pleasure for me to introduce Dr. Thomas Nickolas, who's a professor of medicine and chief of the Division of Bone and Mineral Disease at Washington University in St. Louis. He got his MD from Pittsburgh, did medicine at Penn and fellowship at Columbia, where he was faculty for a long time. And his area of interest is skeletal disease and the effects of kidney in both adults and children, and advanced in novel ways to phenotype what's going on in the skeleton. But I just want to make a couple other comments. For those of you that don't know, the Bone and Mineral Division at WashU has a storied history. It's really famous. It's independent from an independent division from other divisions. Started, I think, by Dr. Avioli many years ago, and many famous people there, Dr. Teitelbaum, Dr. Haddad, who I trained with, Dr. Pacifici, and Dr. Trivitelli, and many others. And so it's really quite a great place. I want to make a comment on how this came about. For years, I have kind of thought that I was undertreating patients with kidney disease out of fear for doing the wrong thing. And I heard Tom give a short talk, a 20-minute talk at the Own the Bone thing, which is mostly directed at nurse practitioners and orthopedic fracture liaison services. And I said, we got to get this guy here. We have to learn what he's doing. And so as people know, I've been waiting for this for several months, and I'm really thrilled that you're here, Tom. Thanks for coming.
Thanks for that kind of introduction. So just so that you also know, I'm not an endocrinologist. I'm a nephrologist, but I kind of think of myself as a nephrochronologist because although I trained as a nephrologist, I spent so much time working with the endocrine group and learning about bone endo. So I kind of bring these two worlds together, which I think is very important for this particular patient population. So I'm going to talk about bone health in CKD patients, and it's going to be kind of a whirlwind talk about things. And these are my disclosures. And our objectives today are to introduce this term, which I do take responsibility for, this term CKD-associated osteoporosis. It's not very popular amongst neither endocrinologists nor nephrologists, which I think is really important that it's generating controversy because that was the point. And then we're going to try and understand the rationale for considering bone health in CKD patients. I want to give you guys a strategy to manage bone health. A lot of this really at this point is not evidence-based or hand-waving since we lack the primary clinical trial data in this population. But I don't think that we can sit around and watch them dissolve, and I'll talk about why during the talk. And then that hopefully will bring us to appreciate the potential benefits and limitations of bone treating CKD MBD patients. So I just like to use this as an example of the heterogeneity of bone disease that presents in the CKD population. So here you have the same person, a 73-year-old woman with a femoral neck fracture, and they all have a femoral neck T-score of -3, and their GFR is all 30 cc's per minute. So all CKD stage 3B. They look absolutely identical. And you could think to yourself, well, I can apply any algorithm I want to treating their bones, like for post-menopausal osteoporosis. But take a look then at their medical history. Patient number one has had an AKI event about 6 months prior, had poor renal recovery, and now has new CKD. Really has no other past medical history and takes one drug for her hypertension. Patient number two has hypertensive CKD for a long time. Past medical history is notable only for hypertension, and then takes a bunch of drugs because it's severe hypertension, takes a phosphate binder, and then vitamin D3. And then patient number three is like your classic ESRD patient that has a history of a kidney transplant, failing transplant, being on dialysis, has lupus as the cause of her CKD, so a total history of inflammatory diseases, and then takes a bunch of medications that are toxic to the skeleton, including glucocorticoids, and then also takes calcium D3 and cinacalcet. So as you can see here, these are three very different patients in terms of their bone disease, but yet if you just look at their T-score and their GFR, they all look the same. And it's really important for us to ask ourselves a couple of essential questions. Who has osteoporosis? Who has renal osteodystrophy, whatever that is? Can they have both? And at the end of the day, does it matter? And then how do you utilize that information to develop an algorithm for each of these patients by themselves? So it's important for us to remember that 1 in 10 people on the planet have CKD. That's a lot of people. And CKD itself is a prominent marker of bad outcomes, in particular for fracture, also for a number of other things, but we're going to talk today only about fracture. And we know from multiple epidemiologic investigations that when we take the general population here in this black line and look at patients with CKD and their risk of hip fracture, that across the life course, CKD patients have higher fracture rates than patients just like them, but with normal kidney function. Patients with CKD have an advanced aging skeletal phenotype. So our youngest patients, who should have no or minimal risk of fracture, have risk of fracture that basically is the same as people 20 years older than themselves. And we know that rates of fracture increase in proportion to the severity of CKD. So we have a population of patients that have markedly higher rates and risk of having a fracture in the general population. And then to make matters worse, after our patients have a fracture, their risk of poor clinical outcomes is even worse than patients just like them, but with normal kidney function. So if we think that after a hip fracture, mortality rates increase by 1.6-fold in patients with good kidney function, if you're not on dialysis, then you have a hip fracture, your mortality rate increases more than 2-fold. And if you're on dialysis, in comparison to someone just like you, but with a normal kidney, your risk of dying increases by 3.5-fold. That's pretty bad to watch them sit there and just fracture. And then, of course, those increased poor mortality rates, not even just that, but after a fracture, patients with CKD have a lower risk of returning to their pre-fracture level of functionality than kidney healthy patients. So all of these costs in terms of hospitalization, surgeries, SNF placement, physical therapy also translates into increased cost to the healthcare system that also rises in proportion to the severity of their CKD. So this provides a lot of rationale as to why we should think about this population in terms of being high risk and treating them for their fractures, for fracture prevention. And the overlap between CKD and osteoporosis is quite high. So when we take a look at national healthcare data sets, in this setting, these are NHANES data, and we look at the problem from two different angles, we see a very, very high co-prevalence of both CKD and osteoporosis. So these data here to the left, these represent data from NHANES, where we compare rates of osteoporosis in patients who had CKD defined as a GFR of either less than 60 or kidney healthy participants, a GFR greater than 60, and the co-prevalence of osteoporosis was 2-fold higher in patients with CKD. If we look at this in the other direction, where we take patients with a known diagnosis of osteoporosis, and we evaluate the co-prevalence of having moderate to severe CKD defined by GFR of less than 35, more than 80% of women and half of men age greater than 60 years have a GFR less than 35. So here we have two populations of patients that overlap almost entirely, and no matter whether we're endocrinologists or nephrologists, we're going to see these patients in our clinics, and we need to know what to do with them. So this is the rationale for the change that was made by KDIGO in terms of terminology, which has not been fully accepted yet in terms of a statement put out by KDIGO. This is something where we're contemplating what it means. We published a consensus statement from our 2023 meeting, and we're waiting for public input. And when there will be a guideline change to KDIGO, we may change the terminology. But we have noted in nephrology that over the past several decades, that the kind of bone disease that presents in our patients, known as renal osteodystrophy, kind of has this mysterious smell to it. It's this black box where, we put a lot of stuff into it, but nothing ever really comes out of it. And we've had many, many trials on renal osteodystrophy and biopsy studies over the past several decades, and we really haven't seemed to have learned anything about it. We have really no treatments for it. And our patient-centered outcomes, including fracture and mortality, really haven't budged. And I'll show you data on that momentarily. So we have these two entities. We have renal osteodystrophy, a bone disease, and then we have osteoporosis, which is kind of an umbrella terminology for bone diseases that alter the skeleton and increase risk of fracture. So we have these two bone diseases that we've been taught are completely opposite each other, and they should never be mixed together. And our diagnostic tools and therapeutic interventions are completely separate. However, osteoporosis, when we think about it, is a condition of reduced bone strength that results in increased fracture risk. Renal osteodystrophy does contribute to fracture risk, and it makes sense to include renal osteodystrophy as a secondary form of osteoporosis, we think, to kind of alter our thinking about it, to make it less mysterious, to give it something that has a more clinical name to it than renal osteodystrophy. And we do this for a lot of other metabolic bone diseases. So we do it for diabetes, we do it for rheumatoid arthritis, and we also do it for GOP. And while we recognize that this may confuse people saying, well, osteoporosis, can we just get a bisphosphonate? We also, as a position statement, recognize that the diagnostic workup, therapeutic plan for patients with CKD and bone disorders has to be very personalized. It's the poster child for personalized medicine. And the therapy plans must be individualized to the underlying kind of bone disease that's present. As you saw from those three cases, you can have the same T-score and the same fracture site, but depending on what the skeleton has been exposed to over the course of that patient's CKD, may alter their therapeutic needs. Our traditional thinking of CKD, mineral and bone disorder, or CKD MBD, has classically focused on this triad of laboratory abnormalities, PTH, phosphorus, calcium, vitamin D, on the bone abnormalities of the classic renal osteodystrophy, and then the vascular calcifications that present in renal failure patients, which predisposes these patients to both increased cardiovascular risk, fractures, and then, of course, mortality. Our clinical trials, our studies have all been based on the biochemical aspects of CKD MBD, thinking that this would help us solve these problems. And our physicians in the dialysis clinic and in the renal offices focus really solely on, well, what's the PTH, what's the vitamin D level? And despite all of that work, nothing has happened to these main clinical outcomes. So we still have high fracture rates, and we still have high cardiovascular mortality rates. So this led us to think that maybe we need to think about this from a population perspective in order for developing and thinking about clinical trials, to think about this in terms of what's important to the patient. So for the patient, it's important that I'm going to have a heart attack or a stroke, or I'm going to have a fracture. So we came up with these terms: CKD-associated cardiovascular disease and CKD-associated osteoporosis. And we recognize that they are the confluence of multiple risk factors, so both traditional and CKD specific. And these things that we have been focusing on, meaning the PTH and the vitamin D, the phosphorus, they're not things that we should look at as being the treatment for the disorder, but these are the things that we should focus on for diagnostics. Because we know from clinical trials that when we treat them, nothing really budges in terms of these important patient-centered clinical outcomes. So for example, these data here that I'm showing you right now are general population data over a 20-year time period when medications such as bisphosphonates were being introduced and when DEXA screening came on board. So we had really great risk classification programs developed and implemented in great job. That decrease in fracture rates was significant. Now, when we overlay what was happening at the same time period in CKD patients, we can see that over the same time period, central fractures in blue and peripheral fractures, which are the cortical bone type fractures that are susceptible to hyperparathyroidism in red, we can see that there was basically a doubling in fracture rates in the same time period. In 2004, cinacalcet was brought to market in dialysis units, so a highly effective way to decrease PTH levels. And as you can see, in particular for the peripheral fractures, the red fractures on the bottom, there was no decrease in fracture rates for those cortical bone fractures. So despite targeting PTH as a treatment, fracture rates really didn't budge. And to make matters worse or similar in terms of clinical trials, this study utilized something called DOPS data. So DOPS is a very large international cohort of dialysis patients. So these 45,000 dialysis patients treated with calcitriol, so our main vitamin D receptor analog, along with others such as Zemplar or Hectorol. And they analyzed these DOPS data for the ability of VDRA use to prevent both hip and any type of fracture. There was zero effect on fracture incidence for any type of fracture or hip fractures when the data was modeled 6 different ways to accommodate their other potential confounders of fracture risk. So VDRAs are great for managing renal hyperparathyroidism, not so good for managing fracture risk. So this idea of focusing, so the prior structure of CKD MBD focused us too much on the biochemical aspects of the disorder and not about the clinical outcomes. And why is that? So we have to think about the risk factors for fracture in CKD patients or for osteoporosis in CKD patients, not as something that is uniquely driven by hyperparathyroidism, but by the other risk factors or the other components of being a CKD patient. So yes, we have the mineral metabolism, but we also have acidosis, we have inflammation, which drives uremic risk factors. We have premature skeletal aging, along with typical aging of the patient. These patients typically have hypogonadism, they have sarcopenia, and they also have lifestyle and dietary changes that make them sedentary. And also they're very malnourished by the time that they reach ESRD. And their bone disease may be impacted by their kidney disease. Are they diabetic? Do they have inflammatory kidney disease? What drugs do they take? So we can't focus, when we think about osteoporosis in CKD, on just one component. We need to focus on the whole entire panoply of risk factors that are available. So it's this holistic approach to the patient that encompasses all of their risk factors. And this feeds very well into this idea of bone quality, bone strength. So we think of this complex phenotype of CKD-associated osteoporosis that really have global effects on bone strength, so on bone dynamics, mineralization, bone mass, bone microarchitecture. And when we think about implementing any kind of a treatment approach to these patients, we have to sequentially target each of these components. Very different from what we do for, let's say, postmenopausal osteoporosis. So, for example, we think about remodeling. So renal osteodystrophy, we think of primarily as a disorder of bone remodeling and mineralization. And this, over the past several decades, has convinced us that since it's only renal osteodystrophy, if we just throw some vitamin D at the patient, we're going to cure the problem. But we've learned that that's not the case. And we've learned that patient-centered outcomes haven't changed. So just to review briefly, turnover can vary from either being totally absent in CKD patients to being hyperactive. So here, this bone biopsy demonstrates that if you look at it, there's not a cell present, and this bone is very quiet. So this is adynamic bone disease. Then here we have a patient with high bone turnover due to hyperparathyroidism, and you can see here that there is trabecular tunneling, excessive dysfunction, and there is peritrabecular fibrosis. And here is the double label from tetracycline, which basically demonstrates a lot of activity. On the mineralization side, patients may lay down bone protein, but just not mineralize it. And here you see this represented in this image where this red This red here represents excessive bone protein. And then on the tetracycline double label, it's not very clear and it's very smudgy. And then here for bone volume, you can see that there is low trabecular bone volume versus high trabecular bone volume. So this was the classic renal osteodystrophy that we were also worried about for decades and treating with just vitamin D and phosphate reduction and maybe some calcium. But nothing much has happened in terms of moving the needle forward to treating our patients better. As part of this phenotype of CKD-associated osteoporosis, we also have to worry about the quantity of bone. So this is a really nice study from Ego Seaman, who used HRPQCT high-resolution bone imaging of the peripheral skeleton. And what they showed was that for CKD patients, in comparison to an age-matched kidney-healthy population, that rates of osteoporosis are higher in CKD patients that we know. We can measure that with DEXA. But what he also showed was very interesting. He showed that for every level of bone mineral density, so whether it was normal bone, osteopenic bone, or osteoporotic bone, that the level of geometric and bone microarchitecture impairments were higher in the CKD patients. So here you have cortical porosity, and here you have cortical area. So a cortical microarchitectural parameter and a cortical geometric parameter. And even when the bone density was normal, there was more cortical porosity and the bone was thinner. For trabecular microarchitecture, similar findings. So here, even for patients who have normal bone mineral density, the degree of trabecular number decreased, and the separation of the trabeculae were worse in the patients with CKD. And then when they applied finite element analysis to these three-dimensional bone images, they demonstrated that at every level of bone mineral density, even for those patients with normal bone mineral density, bone strength was lower. So here you have a phenotype of osteoporosis where all of the components of bone quality are affected. How do you manage this in terms of treating somebody? So the patient coming in with a T-score, let's say -3, or let's say you have a patient coming in with a T-score -1, but they have spine fractures. How do you put this into a treatment algorithm when the patient, let's say, may have CKD stage 4, a GFR 25, a little bit of hyperparathyroidism, a little bit of D deficiency, they're at high risk for a fracture. So what do? How do you implement something? So we've come up with this guideline, which we're sort of talking about now in terms of KDIGO and those of us who are going out and talking about how to conceptualize this. And how do you base treatment on a phenotype that we're just learning about? That's very complex. So this algorithm takes us from initial assessment to a target, and it tries to capture each component of what's going on in a CKD patient, going from the initial point where you identify them as requiring treatment because they're at higher risk for having a fracture, managing their CKD MBD, which is also critically important because it does drive a number of abnormalities in the skeleton, defining their bone turnover, deciding a treatment for their osteoporosis, and then how far do you go? When do you stop?
Okay.
So let's first talk about the initial assessment. So prior to 2017, we didn't even have a test to use to assess fracture risk in our patients. At that time, there were never any large enough DEXA studies in CKD patients to let us know whether or not DEXA was actually useful for determining fracture risk. And there was debate about whether or not BMD even corresponded to fracture risk. And so in 2009, KDIGO met, said we can't make any recommendations. Then there were more studies that came out. In 2017, when KDIGO met, they were like, okay, we have the studies, so now we can make a recommendation. And these studies represented here in the first box were a number of studies across the CKD spectrum, so from healthier kidney disease patients down to dialysis patients, and some of these studies had healthy kidney healthy controls that were involved. And what they showed was that DEXA, using the World Health Organization T-scores, predicted fracture risk in CKD patients similarly to that of patients with healthy kidney function. So there really was no different in how DEXA performed. And the sites that performed the best were basically the total hip femoral neck and the 1/3 radius. Spine, not so much. And as you can imagine in CKD patients, it's a population that's older, high vascular calcification risk, that there's bias in that measurement of the spine for bone mineral density. So spine BMD, not so great, but the other skeletal sites, yeah, they work very well. As for the general population, the relationship between fractures and BMD is the same. So about half of fragility fractures still occur in patients with T-scores above -2.5 in the CKD population, similar to the general population. So how do you then pick up those patients? So we can use FRAX, we can use TBS in the patients, and that has also been explored in CKD patients. Here in the second box comes FRAX study from the largest to date cohort of CKD patients from the Canadian data sets from Manitoba. They included patients across the spectrum of GFR. They divided it by a GFR greater than 60 for normal, 30 to 60 for moderate CKD, and less than 30 for more severe CKD. Here you have normal kidney function, moderate CKD, more severe CKD. They looked at the fracture rates that occurred in the population, and then they looked at the predicted fracture rates using bone mineral density, here in red, and no bone mineral density, just FRAX alone, here in green. And as you can see, the predictive capability of FRAX performed equally well across these GFR categories. So FRAX is accepted now as a tool that we can use also for patients with CKD, both with or without bone mineral density. For TBS, for those of us who use it, it can be a very good tool to help us determine patients who may be at a higher risk of fracture, and we can adjust their BMD based on the TBS score. There is some data in CKD. I think we have more data in pre-dialysis CKD. There are large cohort studies that have used Canadian data sets in particular, where they've applied TBS to these fracture cohorts, and based on their GFR, they have determined that TBS works very well at predicting fracture risk in pre-dialysis CKD patients. For patients on dialysis, at this point, we only have cross-sectional data. However, in these cross-sectional studies, TBS does discriminate fracture status. So it's very promising, and we're waiting for. So we have multiple tools by which we can identify patients with CKD for their fracture risk now. But then once you do that, and you have your patient who's at higher risk, then what do you do with them? So the next step in this algorithm is to optimize their mineral metabolism. So focus on these abnormalities that may drive metabolic abnormalities that may affect the skeleton, such as, are they D deficient? Are they very hyperparathyroid? Do they need to have their parathyroid glands removed? If they have severe hyperparathyroidism, what's their calcium, their phosphorus? And then after you've done that, what's their bone phenotype? What is their turnover after you're done? Because they're always going to have a component of renal osteodystrophy if they have severe CKD. But then what is it after you treat all of this other stuff? So the basics here of mineral and bone disease management are pretty easy to talk about. To make the patients do it and to implement, it's a little harder. So the first thing is, what do you do about phosphate lowering therapy? So lowering phosphate is a big challenge for CKD patients. Otherwise, if they were totally phosphate restricted, they would become malnourished, because phosphate really is in a lot of different food types. And no studies have really shown that even with maximal phosphate binder use, do you get super good control. It's very hard to implement in the dialysis clinic. So KDIGO basically says that we should ask our patients, try and work with them what they want to do, refer them to a nutritionist, first do dietary interventions, and then if that doesn't work, focus on medication therapy. The risk for hyperphosphatemia can be severe, including calcifications and cardiovascular risk. So we try and focus on this, but it can be very challenging to do. Calcium balance is a big topic in nephrology because everybody thinks that calcium is bad for the patients. They're worried that if you give them too much calcium, they're going to calcify and you're going to increase their cardiovascular risk. When you have osteoporosis, though, you do want to make sure your patients are in calcium balance. And this can be a very challenging discussion to have with your nephrologist because they may be very resistant to giving calcium. I've had a number of interesting conversations with nephrologists who refer patients to me and then don't want to give them calcium as we're about to put the patient on Prolia and make them hypocalcemic. So it can be a challenging thing to do. But the history behind this is very interesting. So just a brief summary of calcium balance in CKD patients. Of course, we get calcium, through our diet and, through our skeleton. And then, of course, we excrete calcium through our kidney. But then when the kidney fails, we hold on to all this calcium. Not much calcium is cleared by dialysis. So basically, you have patients who will eat calcium, can't excrete it, and then they may put it into their vasculature. That's the fear. For a 20-year time period, beginning in the 80s, we viewed calcium as a way to control hyperparathyroidism, and patients were getting a ton of calcium. Until this concern happened around 2000, that we were basically killing all of our patients because they were calcifying and they were having heart attacks and strokes. So then this idea came about that we should just prevent calcifications and we should restrict calcium use, and we should basically let our dialysis patients ride at the hypocalcemia. Very accepted. And in fact, if you go to the dialysis unit, they drive the calciums a little bit lower. Even on cinacalcet, they'll let the calcium drop a little bit lower. You don't worry about it unless they're symptomatic. Okay. So recently, an article came out talking about how bad this is. So this was a very interesting study where they looked at something called hidden hypocalcemia in the dialysis unit, where they were monitoring patients on dialysis and checking their ionized count. Those patients who had more frequent dips of their ionized calcium during the dialysis procedure, in the long term, had higher cardiovascular mortality rates. So cardiovascular mortality in dialysis patients is not really driven as much by plaque rupture as it is by arrhythmias. So by keeping our patients hypocalcemic and provoking hypocalcemic events, we were driving arrhythmias that basically were killing our patients. So the recent KDIGO meeting kind of touched on this, and we tried to say in the statement that we should worry about calcium balance, particularly in our patients who are losing bone mass or becoming osteoporotic or having fractures, and we should focus on not keeping them so restricted on their calcium intake. The Europeans, the European Renal Society is much better than the ASN at coming up with recommendations or consensus statements based on available literature. And they recently came out with a really great consensus statement across the life course, so from kids to adults, where they evaluated the literature on calcium balance renal failure patients. They came out with a consensus that we should be maintaining calcium balance between 800 milligrams and a gram of calcium a day from any source. So whether it's through a dietary supplement or through their diet, which I think is a really important statement, because there's really no way for us to manage these metabolic abnormalities that affect the skeleton if our patients are going to be hypocalcemic, and also if we're giving our patients these bone drugs which rely on mineralization to occur after we give it to them. We will never solve the osteoporosis problem. It may make it worse for some of these patients who may get like a bisphosphonate, then can't mineralize their skeleton. So we'll see how this affects practice patterns. I mean, I still have frequent conversations with my nephrologist about this, and they're very, very resistant to give calcium because there's this kind of beat into our head during training that calcium is bad. So it's a very interesting problem that we'll see whether or not it evolves once these guidelines from KDIGO change. For vitamin D, there's also been, like lack of clarity in the dialysis in the CKD community about what vitamin D level should be. There's no hard clinical trial data on optimal vitamin D levels. There are a ton of small trials on nutritional vitamin D. There's a lot of observational data. Once again, the European Renal Society has come out with a consensus statement where they looked at vitamin D levels and bone outcomes and cardiovascular outcomes and CKD outcomes across various studies and across the life course. And the recommendations are basically similar to what we see in the general population, to keep the 25D levels greater than 30, and to avoid active vitamin D only unless those patients require calcitriol therapy. So for late stage CKD and patients who have progressive hyperparathyroidism after you've controlled everything else, which is what this statement says. So then after then you have done all this stuff, after you have taken your patient, risk stratified them after you manage their mineral and bone disease, then you need to start considering, what kind of therapy is good for them. And I think here is where the controversy begins. I don't think it's controversial for anybody in the renal or endo communities to treat their mineral and bone disease or to fracture risk classify them. Do you have a question? Oh, sorry, I thought you had a question. And you can ask questions from the crowd. Feel free. This will be very interactive. So I think what happens next is more controversial because of the lack of clinical trial data and then the controversy about whether or not these drugs are harmful to the skeleton or to the kidney. So, all right, in the osteoporosis world, there's a ton of drugs that have been developed and FDA approved, and these drugs work phenomenally well. However, when you take a look at the state of what's going on for the CKD world, do we have any FDA approved drugs for CKD osteoporosis? And the answer is no. So everything that you're going to do for these patients is going to be off-label. Okay. Biochemical targeting for bone treatment, I've already demonstrated to you in the prior slides and on this slide here of the use of calcitriol to prevent fractures. Biochemical targeting alone doesn't do the trick. Okay. Why is that? Likely because when you develop abnormalities to bone quality, your trabeculae become disconnected, your cortices become porous. If you just lower their PTH or give them vitamin D, you may fix the turnover, but that's not the only thing about fracture risk. So fracture risk depends upon microarchitecture and other things also. So you're not going to fix that stuff. You need a big, powerful drug for that. Cinacalcet, we talked about that before, that in most studies it hasn't shown to have a fracture benefit. If you do a meta-analysis, maybe there's a fracture benefit, but it's unclear. So once again, another example of biochemical targeting not really working. So the PTH story in renal failure is kind of complex. So yeah, we all know that when you get renal failure and your kidney increases and you can no longer make active vitamin D, that your PTH increases to basically compensate for that and try and force more calcitriol to be made, and also to get more calcium absorbed from the gut, and to make the kidney get rid of more phosphorus. But in the skeleton, what happens is that very, very early on in the course of CKD, your bone begins to produce more sclerostin, and your bone it develops lower turnover, and it becomes less responsive to PTH. No one really knows why. There are theories that these uremic toxins that are circulating, and maybe it's phosphorus, maybe it's something else. We use uremic toxins as a kind of basket thing in nephrology. Unclear why. Some people think that the lower turnover that begins in CKD is not maladaptive, but actually it's protective. And the PTH hyperresponsiveness probably protects the skeleton from dissolving early on in the course of CKD. Maybe. Unclear to me. Because if you think about it, PTH kind of doesn't begin to rise until your GFR hits about 25 to 30. And we see these changes in PTH responsiveness when GFRs are already at like about 70, so near normal. So it's really unclear why. But when we look at the relationship between PTH and clinical outcomes that nephrologists care about, so in here we have all-cause mortality, we have cardiovascular mortality, non-CV mortality, bone fracture, and then hip fractures. We can see that maybe for fractures, maybe there's a linear relationship. I mean, maybe. We can see that for mortality, there's this U-type relationship, and we can see that that's present also for all-cause mortality. So when we think about how we should be treating bone and CKD patients, PTH doesn't seem to be a great marker for a number of important clinical outcomes. But if we think about what the bone cells are doing, so here we have PTH, which may regulate bone function, but it doesn't really tell us what the bone cells are doing individually. We do have ways to do that. We have bone turnover markers. And this was a very interesting study that used total alkaline phosphatase, which is, and these are dialysis patients in this study, which is measured on a monthly basis in the dialysis clinic. And what they did is they took levels of PTH. So because this was from this DOPS study, which was this international cohort of dialysis patients, the same PTH assay was not being used. But to accommodate for that, they normalized the PTH on a dialysis unit basis by the reference range reported by the unit. So these here correspond to PTH levels on a unit basis normalized to the unit's reference range, and then you could compare them all together. Okay, so these are grades of increases in PTH, and then they did the exact same thing for alk phos. Okay, so for every level of PTH, okay, if you look at the alk phos, higher levels of alk phos at any level of PTH corresponded to an increased risk of fractures. These are all bone fractures. So in terms of how we should we think at KD go, in terms of managing bone disease, is you treat your PTH for the hyperparathyroidism, because that's bad. We know that hyperpara drives a lot of bad things for dialysis patients, and if they get a transplant, we know that they're going to have allograft dysfunction. So you want to control their hyperparathyroidism for a number of things, but when you're going to focus on their skeleton, focus on the bone turnover, focus on what the bone cells are doing, and that should drive your therapy. So you could have a high PTH, but a low bone alk phos. That should risk classify your patient to a lower category of fracture risk, and maybe that patient does not need a bone therapy. Versus a patient with a low PTH, but maybe their alk phos is through the roof because they're really resorbing their skeleton. That patient maybe should be a higher target. So base it on a marker of bone cell function, so something very physiologic, rather than PTH, which tends to lose this relationship to the skeleton as patients progress through their CKD. So there have been, over the past 40 years, multiple bone biopsy studies that have evaluated the utility of these bone cell markers, so osteoblast markers, so bone alkaline phosphatase, P1NP, osteoclast markers such as TRAP. These are non-renally clear bone turnover markers. They've evaluated the ability of these bone turnover markers to identify bone turnover as a prelude to selecting therapy, either an anti-resorptive or an anabolic agent. So these data come from a recent IOF paper that came out, I think January of last year, and they presented data across the spectrum of metabolic bone disorders, but there was a section on CKD and MBD. They took the 3 biomarkers that are in clinical use in Europe for metabolic bone disease, so bone alk phos, intact P1NP, and TRAP. Here in the US, we can't get TRAP clinical use. However, we can get BSAP and intact P1NP. These studies were in decent sized cohorts of patients. Some of these studies had almost 500 patients, 200. They were across the categories of the spectrum of CKD, from dialysis, transplant, pre-dialysis CKD, and these were international studies from Europe, South America, United States. What they showed was that the discrimination for differentiating low from non-low or high from non-high was very similar across the studies, across nations, and across assay use. So these studies occurred over a 20-year time period, and the assays for these biochemicals changed over time, but the discrimination didn't change. And I bring this up because I think it's an important point, because then when they evaluated the cutoffs for these different assays for differentiating low from non-high and low from non-low and high from non-high were also very similar across the assay types. So what they say is that, to me, that we have a non-invasive test that can tell us what the bone turnover roughly is, and we can use any of the assays that are clinically available, and we can kind of guess what the right cutoff is going to be for these assays. Now, you could basically look at the assay that your lab is using, go to this paper, pull the assay type and look at the specific cutoff, but you're going to be pretty much in a range where you know what's going on when you get your lab back. And the reason why we say low from non-low and high from non-high is that you're differentiating low from a mix of patients with normal turnover and high turnover. And the same thing on the opposite side. You're differentiating patients with high turnover from low and normal bone turnover. So when you're thinking about whether you give an anti-resorptive or an anabolic agent, you don't want to give a patient with high bone turnover anabolic, nor do you want to give a patient with adynamic an anti-resorptive. Patient with normal bone turnover, you can do whatever you want with. So this, I think, is very helpful. To me, this means that we really don't need bone biopsies for the vast majority of our patients. I reserve bone biopsies for my patients who confuse me, for my patients who maybe they have osteomalacia, but I'm not sure. Patients who, let's say, are very complex, like they're on dialysis, they have a transplant, they have cancer, and they're on weird drugs. Those are the patients who I'm like, I don't know what's going on with their skeleton, and maybe need a biopsy. In those cases, the biopsy can be useful. But in a run-of-the-mill patient on dialysis, I don't really find biopsy. So what's the state of the literature supporting the use of these medications for patients with CKD? So we have bone targeting therapies that are being used across the CKD spectrum. We have the FDA registration trials like those for bisphosphonates. I'm not going to show you the trials for Evenity, nor for the anabolics, nor for the other bisphosphonates, but basically here's an example. I think we have great data for patients with CKD stages 1 through 3A for the use of any of the FDA-approved drugs. These FDA registration trials specifically didn't enroll patients with CKD, but they had a number of patients that had lower GFR when you apply a GFR estimation equation. Whether these patients had true CKD or age-related declines in kidney function is a whole entire talk by itself. But basically, these patients, there's data in this group of patients, and it does show that these medications increase bone mineral density and decrease fracture rates. So this, I think, is the only population of CKD patients where there is FDA approval for the use of these drugs. And you can kind of treat them like regular kidney healthy patients. However, that being said, for patients with later stages, CKD 4 and 5, we don't really have any good data. And we don't really have any good safety data. We have a lot of studies right now suggesting that maybe there's a problem. So this was a recent JBMR article that suggested there was a 14% higher risk of CKD stage progression, including to dialysis and kidney transplantation in patients who were given 3 to 5 years of an oral bisphosphonate. We have the data that came out that was published in JAMA a few years ago, which showed that in patients on dialysis who were given denosumab, that they had incredibly high rates of hypocalcemia that result not just in hospitalization, but a 2% increase in mortality. So we have all of these drugs that we're using in CKD patients that I think are fine to use, but if we're going to use them, we have to be aware of what the risks are, and we have to talk to our nephrologist to make sure that we're that best. And this is, I think, another tricky point. I don't think that bone care for a late-stage CKD patient should be done by an endocrinologist alone, nor a nephrologist alone, because they have no idea what these drugs can do. I think that it has to be combined care, whether it involves some sort of like a multidisciplinary panel of physicians, or whether you just communicate regularly with your nephrologist. It has to be in conjunction. We'll talk about why momentarily. For kidney transplantation, we have a number of small trials that have looked at bisphosphonates in this patient population. And, the most recent Cochrane analysis, or the most recent meta-analysis, suggested that basically bisphosphonates can prevent fractures in kidney transplant recipients. This is a very specific population that differs a lot from the general CKD population. And I'm not going to focus on this population that much beyond this one particular slide. So what do we know about these meds in CKD in patients with moderate to severe CKD? So we have a ton of observational data for all of these drugs. And it shows that for all of them, they result in, at least for early stage CKD, as we said, we have BMD increases and fracture risk reduction. Okay. We have a lot of concerns for safety concerns. There's a question about kidney damage and oral bisphosphonates. So if we know that fracture rates increase in parallel with kidney disease severity, I think we should be beholden to preserving their kidney function. So do you want to give them a bisphosphonate if it's going to make their kidney function worse and increase their fracture risk? I think it's something that we have to consider and think about. If we give DMAB, maybe they become severely hypocalcemic. And then with the PTH analogs, maybe they become hypercalcemic and hyperuricemic. Maybe it can drive calcification risk, and hyperuricemia be associated with also increased mortality. And then for Romo, there's this, this question about cardiovascular risk. And do you want to give this drug to a population of patients at extremely high cardiovascular risk and also extremely high risk for vascular calcifications? And I think that's something that you need to consider if you're going to give it. I've given it to my CKD patients, but I typically send them for vascular calcification screening, and I do a really good cardiovascular risk profile, and I give it if I feel that it's safe to give them. Because sometimes you have to give it. Sometimes it's the only drug to give. So how about the bone turnover thing? So I'm up here talking about how you utilize these bone turnover markers to determine which therapy to use and how to justify use of, let's say, an anti-resorptive or an anabolic agent for a patient with low or high bone turnover. So I think this is very interesting data. These data here come from a denosumab trial, small, 47 patients in dialysis, 47 dialysis patients. And here you have the change in lumbar spine bone mineral density at 6 months. And there you have, here you have bone alkaline phosphatase. When you look at the response or the non-responders to DMAP therapy, it's this group down here. So it's those patients who had lower levels of alkaline phosphatase. So the patients who already had lower turnover, you assume, based on the BTM, are the patients that really had no response to drug therapy. And those patients who had the best response are those patients who had higher bone turnover, or you assume by bone turnover. So, once again, we don't have the clinical trial data in nephrology. We probably never will have the data. However, we have a lot of interesting observational data that does suggest that this approach of looking at the bone turnover, so do something very physiologic and very precision medicine based, probably is the right thing to do for the population. We have data in dialysis patients using teriparatide. So here in this cohort, a very small cohort of dialysis patients, you can see that in those patients who were given teriparatide versus the control group over 12 months, that there was a significant increase in bone mineral density in the active drug group versus nothing really going on in the placebo group. And then we also have data for Romo in dialysis patients. And here we have the change in lumbar spine BMD over 12 months in a group of dialysis patients given romosozumab. And when we look at their biochemical data, we see the exact same thing in these dialysis patients as we see in the general population. So if you look at the top figure, this is bone alkaline phosphatase. You see a beautiful anabolic window that occurred at first 24 months of therapy. And when you look at their TRAP levels over that same time period, TRAP doesn't change. So they had a nice bump in formation, nothing going on with resorption, which is exactly what you would expect from Romo. So the physiologic effects of these medications are very similar in CKD patients as they are to the general population. You just need to know how to use them. You just need to know what to look out for and be extra cautious for a few things. So let's talk about the study now about CKD worsening and outcomes. I don't like this study. I think it's a horrible study. In none of the FDA trials did they ever find any effect of oral bisphosphonates on CKD or on GFR. These data come from administrative data sets that came out of the UK and the Catalonia region of Spain. They coded the patients based on ICD-10 codes, and they looked at 3 to 5 years of oral bisphosphonate use, and their event rates were basically a change in ICD code from no CKD to 3 to 4 to 5 or to dialysis or transplant, just based on the code. So let's just say if you have a GFR of 31, your CKD stage 3B. If your GFR goes to 28, that's an event. You went from 3 to 4, okay? If you have a GFR that goes from 28 down to 16, okay, your ICD code does not change. The change from 31 to 28 is irrelevant and probably just range of error of the serum creatinine assay, where the change from 28 to 16 is critically significant. Okay, doesn't pick that kind of stuff up. Okay, and also you can't really rely a lot on ICD-10 coding because it may be very variable depending on the visit. You know, there are a number of reasons why ICD-10 coding. This study also did not pick up on rates of proteinuria, and proteinuria correlates highly with fracture risk and also with CKD progression. So what did they find? They found that when they looked at a propensity score match model for CKD progression risk in the cohort, that there was pretty similar, 14, 15% in each region, combined 14% increased risk of CKD progression. When they looked for interactions, there was an interaction for fracture and CKD progression. Well, once again, they didn't look at proteinuria because they couldn't. Proteinuria is the biggest risk factor for CKD progression. It's also a risk factor for fracture. So it's unclear what this means. They looked at male-female interaction. There was more risk of progression in female, which kind of doesn't make any sense from a kidney perspective, because usually it's men who are at higher risk. And then in terms of the number needed to harm, it was over 5 years, 21 and 28 in the Spanish cohort. There was a mortality risk benefit in the UK cohort, but not in the Spanish cohort. So I mean, this is data that I think not sure how I feel about it, but it's out there. It's published in JVMR. Also, there's another one that published in data that's similar. They came out a few years later. I'm not sure if I believe it. However, you need to know about it because your patients will know about it. And my approach after this article was that so these data correspond to 3 to 5 years of bisphosphonate use. So if I have patients who I think are going to need long-term bone treatment, I stay away from the bisphosphonate and try and give them something else. You do have patients who will need a bisphosphonate eventually. If you're coming off anabolic or you're coming off Prolia, you have to give them bisphosphonate. But can you do that in 1 or 2 years? I think that's possible. So it's less exposure. I don't know how else to conceptualize this because it was never shown in any other study except these ICD-10 coding studies. I've tried to replicate this data. I had a programmer who worked with me for a little bit. He gave access to a bunch of health insurance data, and we couldn't replicate it. It was the bias was too intense. It was very, very messy. You could not believe the parameter estimates. We adjusted and adjusted and adjusted, and then we over-adjusted, and the data still wasn't believable. So I don't know what to think of this data, but you have to work with it. That's all you can do. And then the risk of hypocalcemia. So these data, which were published in JAMA from a post-marketing study of denosumab in dialysis patients, took postmenopausal women in the dialysis unit who were given Prolia, and it found, as you can see here, that there was an incredible risk of hypocalcemia in dialysis patients in comparison to those given reclassed. And the hypocalcemia event rates were quite high. So 41% in the DMAP group, 2% in the bisphosphonate group. About 11% of the DMAP patients experienced a hospitalization due to the hypocalcemia, none in the bisphosphonate group. And then there was a slight but significant increase in mortality in the DMAP group. So what was fascinating about these data, and I wrote the editorial on this, is that none of the nephrologists in the study were giving the drug. It was all provided by non-nephrologists. So you have to wonder, did the nephrologist know that the patient was getting the drug? You have to wonder whether or not they implemented any therapies to mitigate the risk of hypocalcemia. And there are studies out there that show that if you prepare your patients beforehand, you can prevent this from occurring. It's something that scares off now a lot of dialysis doctors having this drug given to their patients. And when you talk to your dialysis providers about this, they also get freaked out, not just by the hypocalcemia, but if they're willing to give the drug, by the fact that they have to give calcium beforehand, because they think that they're going to kill the patient with a heart attack or a stroke. So it's an interesting dilemma. But the data out there on risk mitigation, I think, is pretty strong. So these data come from a group of dialysis patients who were in a 24-week study of DMAP. These are patients who had severe renal hyperparathyroidism. So these are the ones that you would expect would develop the worst hypocalcemia after shutting off their osteoclast response to PTH. So these patients that had an entry criteria for a PTH greater than 1,000, they had a pre-drug regimen where they were put on 3 grams a day of oral calcium. Their calcitriol doses, which were at 1 mic per day, were increased to 2 mics per day, and they had the dialysis, the calcium in the dialysis bath increased from 3 to 3.5. Standard calcium bath here in the US is 2.5. So this was a Taiwanese study. So there they do a little bit more calcium, but here we really restrict calcium. So what happened? So the nadir, so that's come up in gray in that red line, occurred within about 2 weeks of giving drug. So that's a great time to measure calcium levels in our CKD patients. So the first calcium nadir came at 2 weeks, and you can see that there was a concomitant increase in the dose of their calcitriol at the same time to mitigate that hypocalcemia. What was also fascinating, and this is something that maybe the nephrologist will pick up because they also focus highly on phosphorus. So not just did denosumab lower calcium levels, but it also decreased the phosphorus, which is something that I think should intrigue nephrologists more than anything else, since we focus all about phosphorus. Over time, so in the beginning, after you gave the DMAB, that the PTH level increased, but they came down over time to even lower than the baseline PTH that they came to the study with, likely because the phosphorus also decreased. You were doing a better job at controlling their phosphorus, better job at controlling their hyperparathyroidism. Total alkaline phosph levels decreased. There's a beautiful increase in bone mineral density in the group by about 20%. No patient in the hospital with hypocalcemia. So everything was very manageable. So you treated their bone disease, you treated their mineral bone disease, and the patients did well. So I think that these are really interesting data for us to think about if you're going to give your patient denosumab and they're on dialysis. So then finally, hopefully I've given you like a rationale for implementing a very personalized medicine approach to managing bone disease in patients with CKD. And the components here, sorry for this complex slide, but I'm gonna make it a little bit easier. So just remember that the first thing that you should do is manage their CKD MBD, whether it's by suppressing their PTH or maybe in patients who have very, very low PTH, is increasing the PTH, managing their D and their phosphorus. And then after you've done that, maybe for 3 or 6 months, then focus on the skeletal abnormalities. Focus on what the bone cells are doing. Focus on whether or not they have low or high bone turnover and deciding on whether you should be using an anabolic or an anti-resorptive agent. And then consider management. Consider, talk to your nephrologist. Make sure that they're on board with the plan. Figure out, and once again, there's no data on this in nephrology in patients with CKD, MBD, but deciding upon, how often do you measure their DEXA? We debated in KDIGO what it should be here in the US. It could be 1 to 2 years. Some European countries are doing every 5 years. So you have to figure out what you think is the best strategy to monitor therapy based upon their risk, perhaps. Monitor their PTH, calcium, and then co-management between CKD and between the nephrology and endo. For future directions, we have a number of knowledge gaps. For instance, when do you stop treatment? We don't know for CKD and osteoporosis. We apply general population guidelines for lack of anything else, but we don't know with DMAB. Do you stop when their T-score goes to -2? Do you do it forever? We don't know. And we need that data. And we need that data in the context of the physiology of what the bone is doing. This is not run-of-the-mill osteoporosis. This is not GI. This is not rheumatoid arthritis. It's a special form of osteoporosis. And we need to really consider what we're doing in the context of their bone physiology. So in light of that, when we go back to patient number 2, from that third slide on the 3 patients, here I've added in the biochemical information. And so this is a patient with CKD stage 3B, long-term CKD, on multiple drugs for minimal bone disease. And here are your parameters. Here's the PTH, phos, calcium, and 25D level. What would you do?
Are you going to give us bone turnover markers or not?
No. So they're a little hyperparathyroid. Their phos is normal. Their calcium is borderline, and their 25D is okay.
I'm not going to give them anything that causes hypocalcemia without something about that. So if their GFR is 30, that PTH might be highish for that degree, right? I can't remember what the goal range for
So
CKD
so it's basically trying to normalize it.
try normal. So calcium trial first. Or teriparatide.
I'm waiting for other people.
I sent to Joe. I will deserve it.
You do teriparatide? You do teriparatide.
I do that second, maybe, but
Anybody else? Just take a guess.
so what did you do?
Gave a calcium trial. So basically, you want to just try and normalize as much as you can. So yeah, so the pTH was a little bit high, but the calcium was riding low. So is that pTH being driven by the relative hypocalcemia?
I was thinking I was thinking calcium first as well. Do you know what I mean? I'm thinking non-drugs because I don't know his calcium intake and things.
That's relevant. You would do you would do like a calcium calculator, like a calculator on the iPhone. You figure out how much you're taking in, and I would assume in this case that since they didn't give us an option, that the calcium intake is okay. So then the easiest way to raise the calcium at this point is to give them calcium trial.
Yeah.
And then later on, like wait like a few weeks, like maybe like 3 months, 6 months, reach PTH and then the calcium and PTH, and then if you normalize calcium and PTH has come down, then check bone turnover markers, and then decide upon what the right approach is. So in summary, think about bone disease in CKD patients, not black box of renal osteodystrophy and what do I do with it? I need a bone biopsy. Think of it as really being impairment to bone quality and strength. Remember what bone quality is, and then attack the problem based on that. So attack the turnover problem, then attack the structure, the microstructure, and the bone mass problem. And these bone targeting therapies, they're being used in late stage CKD. So why should we avoid them? We just need to pay attention to the safety signals that we're seeing. We're not seeing increased fracture rates in these patients because of these bone drugs. So we do think that they're safe. There will be bone tissue toxicity data coming out soon from multiple investigators who are now getting the data, and we'll see what that shows. But it does seem as if these drugs are safe to use. We see decreases, we think, in fracture rates. However, there are some bad things that can happen if we don't pay attention. And I do really think that this is just a shared management strategy. Like the Europeans now have begun, or the ERA, European Renal Society, has begun now like a shared disciplinary clinic team that they've implemented across the EU, where there's a group of people who meet by Zoom, and their nephrologists are very on board, and they review cases and give advice about what the structures. I think that's a very ambitious kind of way to do it. I'm not sure how effective it can be across a population of 450 million people, but I think it is a very nice thing to consider in terms of what we do in our local institutions about having managed these guys. So thank you very much. I appreciate the time, and hopefully I taught you something.
Tom, I'm waiting for Angela to come in and make the computer on again so people from the outside can answer. So I want to ask a very practical question. Thankfully not in my patients. We've had a couple of patients, thanks Angela, who have gotten anti-resorptive agents while on cinacalcet and developed pretty profound hypocalcemia. So am I right for being too conservative in the patient with secondary, not tertiary hyperpara, but secondary hyperpara on cinacalcet to want to hold it for a little while before at least I start the anti-resorber and then maybe restart it later? So what are you doing before dosing? Patients on cinacalcet for secondary hyperpara, and you're going to give them DMAP. How long are you holding it for?
So I will hold this in the calcet. It doesn't have that long of a half-life. It's a daily drug, so I'll hold it for about 2 weeks, and then
okay. So 2 weeks before.
That should be, that should be okay. 2 weeks, it should be not bad. I mean, it may take longer for the parathyroid gland, I think it's to respond, produce PTH, but 2 weeks should be enough.
Yeah, didn't we see one patient? I can't remember who I heard about it from.
It's Julia's.
Julie.
It wasn't Julia's. I think she signed off on like, cause like.
Right. Yes, that
Yeah.
was a patient who developed profound hospital, and had been on DMAT. It wasn't, I think about this more most of the first dose phenomenon.
I think it happened that
It
fast.
wasn't the first,
It was-
Yeah,
and she got ended up calcium is 6 or so.
yeah.
And so we kind of come to the conclusion that we should stop. And I think,
Yeah, I would stop it, and then, when you're managing the hyperparathyroidism after you get DMAT, make sure your nephrologist knows not to check the PTH until 5 months later. Because that PTH is going to shoot up, and then they're going to want to act on it, and they shouldn't.
yes,
They should just leave it alone. Because it comes down, and typically that seesaw cycle does begin to peter out after 3 or 4 doses of DMAT. But you have to be very careful with them, because the nephrologist will actually refer patients sometimes for parathyroidectomy when the patient doesn't need it. Yeah.
I saw thankfully only after, this is for the fellows, with hypopara, who yours is exactly what happened. The patient had, they did a PTH a month after the denosumab. It was extremely high. The patient needs parathyroidectomy. Patient had parathyroid surgery.
Yeah, I've heard of a few.
Hypoparathyroidism, and then I saw the patient, and it's like, yeah, this is, please. This is,
And that's why I think this needs to be co-managed, because nephrologists don't get training on these drugs at all. They have no idea how they work, and they will do things like that if they're
Like renal bone clinics. That's my.
yeah, it's a multidisciplinary.
It's a partnership thing.
yes.
Yeah.
So I have another, there's questions coming across here, I can't see. I don't see anything, but so isn't there animal evidence that inhibition of sclerostin can increase vascular calcification? Or do you know, I seem to recall this.
Yeah, there's some animal data, and there's a lot of resistance to giving Evenity in the because of some of this stuff, vascular calcification. So it's known that sclerostin is produced and posed by vascular calcification, and no one really knows why. You assume that it's protective. So if you knock it out, it's unclear what happens. So I didn't show this data, but in one cohort of dialysis patients who were given Romo, they measured vascular calcifications, and there was a decrease in vascular calcification for that same time period during the Romo treatment. So it's really unclear, what this means. I don't like to use it unless I have no other choice.
I mean, I know that there's studies out of Korea where they used it, and it's effective.
Yeah.
I
I mean, there may be patients with CKD. It's not chronic kidney disease, chronic kidney diseases. So let's just say, like polycystic. So the polycystic, kidney phenotype is very different than diabetes. They have a very different kind of bone disease and there's excellent, papers published on the bone disorder that presents in patients with PKD, and they have a low turnover phenotype. PKD patients don't necessarily calcify. So, there may be, specific, we need to learn this. There may be specific groups of CKD patients who have a better response to certain classes of drugs based on their kidney disease and on their bone. So if a PKD, so osteoblasts have a primary cilia, which is, the disorder of PKD. So, and they have low bone turnover. So maybe these patients would do well with Romo.
So you alluded to this, and I don't want to just keep going back and forth and take everybody's time, but the difference between kidney disease and age-related renal function decline seems to be a pretty big difference. I mean, what percentage of 85-year-olds, healthy 85-year-olds, have a GFR more than 60?
Yeah.
Probably not very many, right?
Point. Yeah.
So, I mean, because this is also a scenario that we see, but they really had kidney disease. They just.
But clinical outcomes do, like if you take a group of like 85-year-olds and look at their GFR, and if their GFR is 65, but they don't have any proteinuria or any comorbids that would associate with kidney disease, and you compare them to 85-year-olds with GFRs in the 90s, there is a difference in clinical outcomes.
So that makes sense.
I mean, there's something there. We just don't know what it is.
I mean, I have been less, I guess I have been less worried about renal osteodystrophy when they have a GFR of 40 and they're 85. Maybe I'm wrong.
Yeah.
Maybe their PTH is normal and phosphates are normal. I just think I treat them like osteoporosis.
Yeah, it's probably mostly osteoporosis. You know, maybe, maybe there's a mild component of PTH resistance, but we don't know. I mean, unless you biopsy them, you're never going to find out. Do you need to biopsy them? Probably not. I mean, you can probably just treat them with anything.
Okay, does anyone else? I know we're a little over. Does anyone have questions? Anyone else?
I have a virtual question.
Abu Bakr.
Thanks, great talk. So I have two questions. What would you do in case number 3? That's my first question. And my second question. So you greatly showed like it's running from high turnover to low turnover is kind of a spectrum, and you emphasize the importance of identifying the phenotype of these patients. How often would you revisit that phenotype? Whether you did an intervention, knowing that it's still kind of dynamic. They're gonna be high turnover at some point, low turnover at some point. You're gonna treat, and you may drive them to low turnover. So how would you revisit that phenotype?
Yeah, that's a great question. And I think that, when you're giving an anti-resortive and you're going from, let's say, normal to high turnover to, and you're inducing low turnover, I'm not really worried about it. I think you're okay. I worry about the opposite scenario where you have a patient with low turnover and you give them an anabolic agent and then they endogenously convert to high turnover. So let me give you a story. So I have a patient who I was treating back in New York, dialysis patient, really complex medical history, with multiple kidney transplants that failed, hyperparathyroidism. She had a parathyroidectomy, and she came and she saw me because she was having multiple fractures. She was on all of these different drugs. I biopsied her, and she had biopsy proven adynamic bone disease. It's like slam dunk. And so I started her on abaloparatide. And she did well in the first year. She had great increases in bone density, was doing well. The biochemical markers, the VTMs were looking good. She still, despite the fact that she had, 3.5 gland parathyroidectomy, her PTHs, were highish. They were like in the 200 range. But hey, she had adynamic bone on biopsy. So she calls me about 3 months after she had her 1 year bone density, and she like, I just had 3 rib fractures and a pelvis fracture. And I was like, oh my God. So brought her in, and of course, in that setting of an acute fracture, the bone turnover markers are useless. So we biopsied her, and she had rip-roaring hyperthyroid bone disease. And I checked the PTH at the time also, and her PTH had gone from 200 to like 1500, and she was on abaloparatide. So I knew that this wasn't the abalo. So I stopped the abalo. I let her cool down for a little bit, and like about a month, and then I started her on Prolia. So your question is really relevant. When you're treating these patients, their bone disease can change over the course of treatment just because of the nature of what happens to kidney disease patients. So you got to be on top of it. But once again, I think the direction of going from high to low is not really concerning, because that's what these drugs do. They give you low bone turnover. Even for the general population, they give you low bone turnover. But it's the opposite scenario which worries me, because if you have a patient that you're stimulating bone cell function, and then they on their own convert to high turnover bone disease for whatever reason or another, that's when your bone will demineralize, your microarchitecture will get destroyed, and the cortices are going to become very porous, and you're going to have more fractures. And I don't know if that answers your question completely. But then in terms of patient number 3 here, I don't have her biochemical data in front of me. Like I really would want to see her biochemical data. I would want to know what her MBD data are, what her bone turnover markers are, see what needs to be corrected on the MBD side, and then measure her bone turnover markers, determine if I could use them to figure out what therapy would be the most appropriate for her, or decide whether or not I need to do the bone biopsy.
Thank you so much.
Joan had to leave. Thank you for a great talk. And
Thank you. Appreciate it. Thank you so much.